Welcome everybody to this group session, and thanks for everyone for attending. I'd like to begin by acknowledging the traditional owners of the land we are now meeting on here today, and pay my respects to the elders past and present. This webinar is proudly supported by the Cancer Council of Victoria, the University of Melbourne and the Victorian Government. I'd first like to introduce our two presenters for tonight's webinar, Professor John Emery and Professor Alex Bouchoutis. Got that right, didn't I?
Absolutely.
Perfect, thank you. Professor John Emery is the Herman Professor of Primary Care Cancer Research at the University of Melbourne and the Primary Care Research and Education Lead at the Victorian Comprehensive Cancer Centre. He is an NHMRC Practitioner Fellow, Director of the Cancer Australia Primary Care Collaborative Cancer Trials Group, and a Visiting Research Fellow at the Department of Public Health and Primary Care, University of Cambridge. He was previously Professor of General Practice and the head of the School of Primary, Aboriginal and Rural Healthcare at the University of Western Australia. He has worked with Cancer Council Victoria on the implementation of the optimal cancer care pathways in Victoria. So welcome. Professor Bouchoutis is a tender academic clinician at the University of Melbourne in the Department of Medicine at the Royal Melbourne Hospital. He is currently the Associate Dean of Graduate Research in the Faculty of Medicine, of Dentistry and Health Sciences. His current clinical positions are Deputy Director of Gastroenterology at the Royal Melbourne Hospital, gastroenterologist at the Peter MacCallum Cancer Centre and Epworth Healthcare. He also leads the GI Risk Management Clinic at the Peter MacCallum Cancer Centre Familial Cancer Service, where his interests include hereditary colorectal cancer and hereditary diffuse gastric cancer. Thanks, Professor Bouchoutis. I'm going to turn off the video of you guys now, so I will get straight into it and I'll hand over to you.
Okay, sorry, we didn't need to. Thanks. So I presume that most of you are familiar with using this webinar software. I don't know whether you wanted to add any more.
Yeah, maybe if anyone has any questions throughout the session today, feel free to send through questions. You will find them in the panel on the right-hand side of your screen. Throughout tonight's webinar, we will also be doing some polling questions. So answer them as swiftly as you can, and we'll endeavour to show you the results as quickly as possible. We usually leave them up for about 30 seconds to give everyone an opportunity. You're all on mute at the moment, so there is no verbal questions. However, I'll be taking written questions throughout the whole entire presentation. I'll filter those and I'll pass those on to Alex and John throughout the presentation, and we'll answer those that come through that I think are relevant and worthy of being answered on the spot. Anything that's not, we'll endeavour to get back to you if we feel that it is necessary.
Sure. Great, thanks Bobby. Okay, so these are the areas that we plan to cover in this evening's webinar. So we're going to be discussing some of the evidence related to prevention and early detection of esophagogastric cancer, and considering some of the initial investigations and referral pathways for people with suspected OG cancer. We'll discuss the evidence around surveillance for Barrett's esophagus, and then present some evidence-based tools around assessing risk of somebody who presents with symptoms, and then what the local referral pathways and diagnostic pathways for people with suspected OG cancer look like. So to begin with, this is our first polling question, and I'll explain why we're asking this in a moment. So please, if you could answer this first question around your awareness of the current optimal care pathways in cancer. Do we get to see the results?
Yep. I'd say a third good, a third fair, and a third poor.
Okay. That doesn't surprise me particularly. That is, of course, partly why we're here today. So this webinar is actually supported through the Victorian Government as part of the implementation of optimal care pathways, which are now a national programme which are really aimed at describing current best evidence and practice for the 15 commonest tumour types, covering the whole continuum of care from prevention, early detection, treatment, follow-up and palliative care. And so they're really about defining what a standard of care should look like for the whole of Australia for patients with these cancer types. They are slowly being implemented across all the states, and there are some key aspects from a primary care point of view which relate to having clear pathways of diagnosis and an integrated pathway of care, and particularly highlighting the importance of communication between the different healthcare sectors and key transition points along the diagnostic and treatment pathways, with the aim to inform quality improvement projects which are beginning to be implemented in various states as part of this national programme for optimal care pathways. So we hope that you will gradually become more familiar with this as you start to see some of these programmes being implemented to improve the sort of quality of cancer care. So we're going to focus this session specifically on esophageal and gastric cancer. And I'm going to begin with just some background around current Australian statistics. So beginning with gastric cancer, so these are the numbers of estimated cases that will be diagnosed this year, so just over 2,300. It's the 15th commonest cancer in Australia, and actually the 15th commonest cause of cancer deaths in Australia. So it's not terribly common, and just over 1,000 people will die of the condition. And you'll see obviously that it's more common in men, and current 5-year survival for gastric cancer is 29%. These are just to show that gastric cancer, both the incidence and mortality has been falling really over the last 30 years. Alex might want to comment later on as to some of the reasons why that may be. Age is, well, you might want to chip in there.
Okay,
like.
sure. So certainly one of the things that's been noticed, and I'll just back up one slide to talk about this reduction in prevalence of gastric cancer. This is a global phenomenon that's been happening, and it's probably related to refrigeration, less pickling, less salting in food, and nutritional improvements in certainly developed nations, and this is what we're seeing across the board in developed nations. The highest incidence and prevalence is in East Asia, and Eastern Europe and South America have got very high prevalence as well. But this phenomenon is also happening with them, but probably less so. What is a bit of a concern that's been raised in our, in certainly gastrointestinal circles, has been the slight plateauing that you're actually starting to see there towards the 2010 to 15. And this certainly is a phenomenon that, again, is being seen across the board, that it may actually be plateauing out now and not reducing much further.
Okay, thanks. So age is probably the most important risk factor, and just to highlight, obviously, again, that it's more common in men, but the incidence really only starts to rise in the sort of early to mid 50s. And I'll point out why that's relevant later on when we start to think about assessment of patients with symptoms and taking age into account as you determine risk of an undiagnosed gastric or esophageal cancer. So age, as I say, risk starts to increase from the age of 50. It's more common in men. Family history is a risk factor, and there are specific familial gastric cancer syndromes that are relatively rare, but with known genetic mutations underlying them. H. pylori infection is an important risk factor, and we'll come on to that later on when we start to discuss H. pylori eradication. And then the other risk factor is smoking, Asian descent, and again, that's probably partly dietary, but also maybe genetic as well. And then specific conditions, pernicious anemia, and more historically, really partial gastrectomy for ulcer disease, though obviously that's a much less common treatment these days. If we then just think about esophageal cancer, slightly less common than gastric cancer, so just over 16,000 people will be diagnosed this year. Again, more common in men. It's the 19th commonest cancer in Australia, but the 12th commonest cause of cancer deaths. And so nearly 1,500 people will die of the condition this year. And as you'll see, the 5-year survival is somewhat less than it is for gastric cancer. And again, some of this relates to late stage at presentation. And again, why early detection is an important part of the ability to try and improve survival rates, both for esophageal and gastric cancer. So the incidence of esophageal cancer is slightly confusing because there are two types of esophageal cancer, and while squamous cell carcinoma rates have been falling, this has been occurring at a time when adenocarcinoma rates are rising. And so you see this sort of relatively flat overall pattern of incidence and a slight reduction in mortality, but not huge. But we'll come on to that discussion a bit later in the context of Barrett's esophagus as well. Again, age is an important risk factor, and again, you don't really see rates beginning to rise until early 50s. And again, I'll flag why this is important later on in the context of assessment of people with symptoms. So again, male sex is again an important risk factor, along with smoking, but again, slightly different other risk factors. So obesity, and associated, of course, with that is gastroesophageal reflux. Alcohol, again, is an important risk factor. So there are some preventative approaches to be considered, particularly for esophageal cancer in terms of smoking and alcohol reduction. And then specific conditions, achalasia and Barrett's esophagus. So we have another polling question before we go on to a more detailed discussion around Barrett's.
So that's about 75% of people. And it's pretty evenly spread between the two, I'd say.
Okay.
With about 20% saying either.
Right. So I'm going to hand over to Alex to discuss Barrett's esophagus in more detail.
Thanks, John. So I've got a few detailed slides here, but I'll just take you through them because I think there's some important aspects here. There's a couple of difficulties that gastroenterologists actually face, or gastroenterologists and pathologists for that matter, and one of them is defining what Barrett's actually is. The strict definition of it is that it requires the squamous epithelium of the esophagus to be replaced with a condition called intestinal metaplasia. Metaplasia is just that change of tissue from somewhere that it shouldn't be, and that doesn't normally grow in that place or have any development in that place. It often is referred to as a columnar epithelium, but increasingly we're requiring specialized intestinalization, which is what this diagram actually shows here. So hopefully this projects well, but this is squamous epithelium, which is stratified, and basically what skin would look like as well, and that's what the esophagus should look like. Then you get these glandular changes here, which are very atypical, and you get a single cell layer over here. This particular area, you can see between these glands is quite inflamed, and this is pretty typical of an inflamed segment of Barrett's esophagus. Intestinal metaplasia is where you actually get some specialization of this epithelium with the existence of goblet cells, and there's some here that you can actually see within the cell structure, within the glandular structure. But that's not an absolute necessity to diagnose this condition, although increasingly it's being used to assess whether someone's risk of developing adenocarcinoma is there. So the importance of this is that it is a definite premalignant condition. The risk is actually of esophageal adenocarcinoma, not squamous. So this is a particular risk factor for the adenocarcinoma, which is the one that's got increasing rates. In Australia, the detection rates, and this is sort of from a study that was published out of Queensland, has shown an increase in patients. Now, this is a bit of a biased sample, but this is effectively what we can try and sample. And these are people having endoscopies. Back in 1990, 0.3% of these had Barrett's esophagus, whereas in 2002, some 10, 12 years later, it went up to almost 2%. This is sort of the graph that I think John was alluding to, and you'll see this sort of graph with esophageal adenocarcinoma, where with increasing time frame, we see an increase in the amounts of diagnoses of esophageal adenocarcinoma, but this is actually referring to Barrett's esophagus, and the Barrett's esophagus diagnosis is that plot there. So you can actually see almost an exponential rise. So again, in terms of definition, it requires two people, an endoscopist and a pathologist. So an endoscopist alone might be able to say, I can see Barrett's esophagus, but one of the difficulties there is where this line, which is called the Z line or squamocolumnar junction, actually occurs. Part of it is related to posture, to eructation, and to potentially a hiatus hernia that could actually make it look like this over here. And so from an endoscopic view on their own, you could get a false positive. But effectively, this is what happens when you get Barrett's esophagus. You get approximation of columnar epithelium, which you see here, and the true gastroesophageal junction is further down. This again is an image of a fairly classical intestinal metaplasia of Barrett's with lots of goblet cells, as you actually see there. Now, what's the problem with it? Why are we concerned about it? And it is because, as John alluded to, it is a premalignant condition with fairly clear progression to adenocarcinoma. I'll take you through this slide, but one of the critical things that we've been thinking about in this space is really this section on the left of the slide here, which is basically the progression through normal squamous mucosa. Because of gastroesophageal reflux disease, you do develop an inflammatory insult that then requires the metaplastic epithelium to establish, or glandular epithelium, and then you can actually get progression through these grades of dysplasia where the cells become more and more confused, if you like, and eventually to adenocarcinoma. And the rates of progression, which have really changed over the years and changed to a lower number, are really something close to this. And it's anywhere between 0.125% and 0.25% over 1 year, developing into low-grade dysplasia. Once you've got low-grade dysplasia, the numbers start to kick off, but the range is still quite broad, and there's lots of reasons for this, and one of them is what truly is low-grade dysplasia, and pathologists argue about this all the time. I'm not going to get into it now, but basically there is a much higher rate once you've got a dysplastic epithelium to actually progress down this cascade into high-grade. Once there's high-grade, some people actually used to believe that if you've got high-grade dysplasia present, you probably just missed an intramucosal or some sort of malignancy nearby anyway. And so up to 60% of people might actually have a adenocarcinoma in the same sort of segment, but very high rates within the next 5 years of doing an adenocarcinoma. So this has to be done, something has to be done about this. I put this in because I think this is a really fascinating story about an evolution of how evolution and genetics actually play a role. And a guy called Carlo Maili actually put this together some years ago. And if you imagine this being a Barrett segment, so this is an esophagus, a picture of an esophagus down the bottom. And this is a Barrett segment over here, with some squamous epithelium here and normal stomach on this side over here. And this is the Barrett segment. So just imagine somewhat this diagrammatically being represented in this white square here. What you can see, and over time, is the development of these mutations that occur in particular cells and in particular genes. And these are particular genes that have been selected, and some of which you might have heard, like P53, CDKN2A. What they mean doesn't matter. Effectively, what this whole picture means is that you develop a clone which then divides and takes over most of the epithelium that you see. And then you develop another clone that also takes over what's been happening here. And you slowly accumulate these clones over time to eventually result in a cancer. And this is what has been thought to be happening throughout this cascade here. So in the earlier phases, you're getting much less of these sort of changes until you get to critical phases down here, which might occur in high-grade dysplasia. And there's good evidence now that says that P53 is happening in that region and that time to actually result in a cancer occurring. The other thing that as endoscopists we always get worked up about is actually diagnosing it endoscopically. So this is a picture that we typically see here on the left, where you've got gastric folds, or the gastric palisades over here, and you've got this sort of salmon-coloured pink tissue and the white, which is normal squamous esophagus. Now, where do we start to measure whether Barrett's is actually present? Do we start here, down the bottom? Do we start at B, over here? Or do we start at A, which is over here? And this has been perplexing us for many, many years. But the best estimate has actually been published and looks like it's the top of these folds here are the best. But this is a very static image. In reality, this is moving like a little snake all the time and making life very challenging for us as endoscopists. But this becomes important because we measure the degree of Barrett's we've got, because that's an important factor in terms of risk of progression of this disease. So how long is my Barrett's becomes a very important question. And we do measure it from what I said, the gastroesophageal junction, which is actually from those gastric folds. But as you can see in this case, you can't really see the gastric folds very easily. So understanding anatomy becomes very important. But it's basically here that we start to measure it. And we measure two things: the circumferential length of Barrett's, which is, if you look at this diagram over here, this is the distance from the gastroesophageal junction. So this will be the level of circumferential Barrett's, and that would be termed C2. And then the mucosal limit of Barrett's, which is here at M5. So this would actually, according to Prague criteria, and there's a group of gastroenterologists had a lovely conference in Prague a few years ago and actually decided on this, and Pratik Sharma is the first author of this. And he came up with the Prague criteria, which actually gave the value of circumferential Barrett's and mucosal Barrett's. So this segment would be C2M5, and in our language, that means that it's a reasonable extent of Barrett's esophagus. Basically, anything more than C3, we start getting more excited about.
Alex, can I just ask a question?
Sure.
So when you've diagnosed Barrett's, would you give that level of information in a letter back to the GP?
Yeah, so this is something that I would expect. So this sort of level of criteria I do routinely on my reports, and I would expect that anyone that does good Barrett's mapping and does Seattle protocol biopsies, which I will go into in a sec, should be actually giving you this criteria, because this is what we basically gauge to determine risk of whether this person is likely to actually have an adenocarcinoma in the future. So I think it is important information to put in a report.
Just a couple of other questions from the audience.
Yeah.
Can drugs, oral drugs, increase the risk of Barrett's?
There's no real drugs that will increase the risk of Barrett's. There's drugs that can worsen reflux. So you can actually get symptomatic issues with that. So it's anything that actually interferes with smooth muscle that's at the lower esophageal sphincter. So if you lessen the contractions of the lower esophageal sphincter, you'll get more reflux, and that theoretically could create Barrett's, but there's not a specific association between certain drugs.
What about alcohol?
Yeah, alcohol's certainly there. As John put in the risk factors for this condition, alcohol is one of the factors that worsens reflux. And in fact, in lifestyle discussions that we have on managing reflux, alcohol, fatty foods, chocolate, caffeine are all things that actually worsen reflux. And sometimes it might be enough for some people with very mild reflux that don't need particular medication.
Thank you.
And does the severity of somebody's reflux symptoms affect their risk of Barrett's?
That's also a good question. I actually had another slide that I could have put on here that actually basically outlined that about 50% of people with Barrett's esophagus have no symptoms. And if you think about it, Barrett's is actually a survival mechanism, or a coping mechanism, if you like, of the esophagus that has been constantly insulted by acid reflux, or alkali reflux for that matter. That also can happen, but predominantly acid reflux that causes damage. And by changing the to glandular mucosa, that damage is not as hurtful. So theoretically, you might have even less people once they've got Barrett's actually having symptoms. So symptoms not great at actually picking Barrett's. So in terms of summarising this section, it's certainly defined. Barrett's is defined endoscopically and with pathology. We do rely on very good pathology to actually find those goblet cells for us, and sometimes it's hard. It is increasing in prevalence, and it remains increasing in prevalence. Esophageal adenocarcinoma also, and that's certainly increasing in prevalence exponentially. And John's slide had both squamous and esophageal, so they almost cancel each other out because one's going down, one's going up. But the one that's going down, we don't focus on too much, but the one that's going up is esophageal adenocarcinoma. We've covered that it's a premalignant condition, and the risk of progression is associated with length, the presence and degree of dysplasia, as I've shown, and to some degree, the degree of molecular changes that actually can be found in it. So, John, I don't know whether you wanted to talk to this, or I can as well, but this is fine. So endoscopically, we then, once we determine that someone has Barrett's of a certain length, then we go through a surveillance we decide whether we're going to enroll someone into a surveillance program. And what's required for that is obviously an endoscopy with this thing here called Seattle protocol biopsies. What that means is that biopsies for a particular segment of Barrett's are quadrantic, so they're basically taken at 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock. And they're taken every 2 centimetres of a segment of non-dysplastic Barrett's. On those biopsies, that's where we get the diagnosis of whether there's intestinal metaplasia or not. And if there is intestinal metaplasia, then you go down a Barrett's protocol down here. If there's not, then you go down this pathway to the right. But if there is, without dysplasia, then that person, depending on the maximal length, and this again emphasizes the length of Barrett's being important. So this is maximal length. If it's greater than 3 centimetres, less than 3 centimetres, then a repeat endoscopy in 3 to 5 years would be in order. And I will say that the caveat here is that we often, well, I shouldn't say often, but in a esophagus that actually has quite a lot of inflammation, we often do another endoscopy at 6 months. That's not unusual because when you've got a lot of inflammation, it may influence the degree of dysplasia that's there because pathologists actually find dysplasia very difficult to diagnose. So that's actually seen here in the second section, which is indefinite for dysplasia. This repeat endoscopy often happens because we need to actually see it in a non-inflamed environment so that the pathologist can very clearly say that the changes they see in the cells are truly dysplastic and not due to inflammation themselves. So I'll go back to the Barrett's without dysplasia over here. If the Barrett's length is greater than 3 centimeters, then a repeat endoscopy in about 2 or 3 years. I usually do it in 2 years in that context, but I'm sort of guided by, again, the Prague level of length of Barrett's that we've got in terms of how frequently I'll do it then. Now, moving on to low-grade dysplasia, that again will repeat in 6 months' time if we did see low-grade dysplasia because of that pathological issue I mentioned. I would refer to more expert centres to actually have this then looked at. And the reason for that is low-grade dysplasia is becoming more and more treatable these days with some of the ablative techniques, which I'll talk about in a second. High-grade dysplasia, as I've implied before, is a concern that there might be if you've taken a biopsy sample just next door to it, you might have actually got the adenocarcinoma. So could this high-grade dysplasia be just adjacent to an adenocarcinoma that's already present? But it certainly has high rates of progression. So for that, we certainly would refer to an expert centre that has a multidisciplinary team that actually discusses these sorts of cases. And often they go for some sort of definitive treatment. If there's adenocarcinoma, often it's surgery. If it's high-grade dysplasia, we usually use either resection techniques endoscopically or ablative techniques with resection if we can actually see it.
The referral to the expert centre, is that something that the endoscopist would usually do?
Not always, I must admit. Sometimes I think they would, and it depends on the practice. And as we all know, there's open access endoscopies around, and they might often send back the patient to a general practitioner, and it might be up to them to actually refer them to a practice.
And so how would a GP know where their local expert centre would be?
Well, that's a good question. I think what was the definition of expert centre? I would say that people that actually could comfortably deal with endoscopically high-grade dysplasia have an available MDM or a multidisciplinary meeting or team that would approach these sorts of problems. That they're the definitions of an expert centre. Also, we've said that over here that you'd need integration of endoscopy, imaging, surgery, and histopathology, and that again defines really an MDM in that sort of context. And that's where I would say an expert centre would be. Having said that, there are expert practitioners that deal with these sorts of conditions all the time, and it really depends on the practice that initially had the referral. And like I said, the open access endoscopy centres may not deal with that, but they may just as easily do that. So moving on in terms of guidelines internationally, these are the ones that are probably the closest to ours. They're, I would say, almost identical. These are taken from the British Society of Gastroenterology guidelines that were published and updated just earlier this year. The update for this year was really trying to clarify that indefinite for dysplasia and low-grade dysplasia, but effectively the same advice is given here. And rather reassuringly, they say the same thing. So for non-dysplastic Barrett's over here on 2 endoscopies, they do want 2 endoscopies to actually define these. And if it's a large segment Barrett's, 2 to 3 years, less than 3 centimetre segment Barrett's, 3 to 5 years, as we've said. If there's dysplasia that's confirmed by an expert pathologist on 2 endoscopies again, and you have these characteristics here, we do treat with high-dose PPI and rescope, and I should say that our current guidelines, which are the ones before, say the same thing. So this is to try and reduce that level of inflammation that I was talking about before. And they have low-grade dysplasia. They endoscope every 6 months. And this is what an expert may do here, because the low-grade dysplastic cases are not advocated all the time for ablative or resection. If there's an obvious nodule, will be resected, but ablation techniques are only now coming to the fore to actually treat this condition. We are much more comfortable treating this condition with ablative techniques, which is the high-grade dysplasia. But again, MDM or MDT discussion and a therapeutic intervention, which could be endoscopic or could be surgical.
Just a quick question.
Yep.
A few questions coming in about PPI use. Can it revert Barrett's?
No, so there's unfortunately no evidence of reversion of Barrett's with PPI. This is an interesting discussion about the value of PPI at reducing the progression rate. There is no randomized controlled data that's currently available that suggests that there's been any sort of regression or avoidance of cancer. There's a recent study that was published in the Lancet in July this year, which was the ASPECT study. Now, this is quite a complex design study using PPI and aspirin in combination and solo to actually look at whether high-dose PPI could avoid the progression we saw. Now, the outcomes that they measured were all-cause mortality rather than progression. So when they subgrouped the data to look at progression of the cancer of the esophageal adenocarcinoma, it wasn't powered to actually see that difference. There was a suggestion that it would improve that, but it wasn't powered to actually do that. So the evidence is not quite there. There was some observational data that suggested that PPI use may actually reduce the rate of progression, but certainly not regression of Barrett's.
Okay, great. What about spicy food?
No, sorry.
Does it increase the risk?
No risk.
No effect at all?
No.
There you go. There's a couple of people that asked that.
No correlation. Although you'll often hear patients that say they've had something spicy and something's happened, that's fine. But that spicy foods is not one of the risk factors that we often see in terms of changing behavior, changing reflux.
Amazing, thank you.
Now, in terms of developments in detection, there's been quite a lot, and I'm not going to spend too much time here, but just to tell you that we just don't use what's called white light endoscopy, which is just the images that I've shown you so far. We do use chromoendoscopy, where we spray things on the surface of the mucosa so we can actually see these glandular structures, which are very nicely pointing out. This is what villi would look like. Which obviously shouldn't be in the esophagus when we can see that quite clearly. That's using sprays. There's technologies with certain instruments that use a filtration of wavelengths of light so that we can only see blue light. And this is an example of one endoscopy company's version of this, where this is the white light image of a Barrett's esophagus segment, and this is what MBI looks like. And again, you can see these almost villus type structures here. And this is what high-grade dysplasia can look like. I mean, even in white light endoscopy, this is magnified, of course. We don't actually routinely use this, but in suspicious areas we can. And we can see these squiggly lines that look very, very irregular. And these are very clearly delineated with MBI. And so I guess the point of this is that there are new technologies that can actually help us identify Barrett's esophagus and even diagnose sort of more complex lesions like dysplasia. But you need a good eye, so you need a good endoscopist that can use these technologies and actually critically takes the time to do this, because this does take time. In terms of therapy, so what do you do about Barrett's once you actually have it? There's a whole bunch of thermal technologies, including now cryotherapies that can be used as well to, to destroy the Barrett's once you've actually seen it. And I'm not going to go through these in detail, but I will sort of spend a little bit of time showing radiofrequency ablation, because this is used quite substantially in these expert centres around town. Mucosal resection increasingly has been used. So this is a technique called endoscopic mucosal resection or endoscopic submucosal dissection, which is a more extensive type of resection that endoscopists, quite expert endoscopists, actually do around town. And one of the complications of ablation, so when you actually do ablate the epithelium that contains the Barrett's, you can stricture, you get chest pain, you can get dysphagia, usually because of those strictures. You certainly can get odonophagia. So those people that use photodynamic therapy can get photosensitivity, but we don't really use this in Australia anyway. And you get this condition called subsquamous Barrett's, which is basically depicted here. So this is overgrowth of squamous mucosa that's buried the Barrett's underneath. When you look at this endoscopically from up above here, you actually can't see the Barrett's. So it's only when you biopsy this quite deeply that you would actually find that there's still Barrett's that still harbors a progression rate, but the exact amount of progression rate is not really known. So this is the halo device that's actually used. This is basically a radiofrequency ablator. So this gets pumped up into someone's esophagus, and I've just got a diagram. So this is a length of Barrett's here. We put the catheter in, we expand it, and we actually burn the esophagus. And that's actually as simple as it gets. And this is one case that's actually had a 4-centimetre segment of intestinal metaplasia extending all the way up here. This was at the time of ablation, so we actually completely denuded all the squame epithelium, and all the mucosa actually sloughed off. And then this is what it was before, and this is what it's like after ablation, after a month of it. So you can get rid of it, and there's certainly good data that actually says that radiofrequency ablation in Barrett's esophagus with dysplasia is a good thing. Back in 2009, this was a landmark paper out of the US that actually showed a very good effect of eradication of dysplastic lesion. And this was the primary primary endpoint for this was eradication of dysplasia, with a secondary one that was really eradication of metaplasia rather than a primary. And this was the data at 12 months after this. So this was randomized controlled. It was controlled with a sham procedure, and the control is in the light blue here, and the ablation is here. And this is basically those people, the proportion of people that had no intestinal metaplasia at the end of 12 months, and it's about close to 80% of intestinal metaplasia, whereas all these people still, almost all of them still had their intestinal metaplasia. This is for low-grade dysplasia and high-grade dysplasia. And there's long-term data that actually suggests, and this is a recent paper this year, that looked at high-grade and low-grade dysplasia in both a UK and US population, same population as you saw in the previous study, but many, many more since then. And this is accumulated data over about an 8-year period. And you actually see very few high-grade dysplastics actually recurring over a 5-year period here, and very few low-grade dysplastics over that period of time as well. So pretty good durability of response. And the other thing that's reasonably new, although a lot of expertise is occurring with endoscopic resection, and this is just a diagram of an endoscope with a cap in it that you inject under the submucosa. Over here, you raise a bleb, and this is the lesion that you want to cut out over here. You suck it in. You then can transect this with a snare, and you're left with a defect here. And this is what it looks like. This is actually an esophageal segment. You can see those gastric folds over here. So all this is Barrett's. And then there's a nodule that's here. You'll have to believe me for it, but because it's very difficult to see on this view. And this was resected by an EMR technique. and taking off all the mucosa very successfully over here. And that grows over very nicely. It can stricture, so we're careful about using high-dose PPIs to actually prevent more damage occurring in this particularly exposed area. So the take-homes I have from this section are really, Barrett's is a pre-malignant condition. Screening to find Barrett's esophagus I haven't really talked about, but there's evidence that it's not really cost-effective, but may have some value. The UK populations have sort of done some study in this space where it might be valuable in very high-risk people. Surveillance programs have been altered to reflect local incidence rates, and that's why there's 3 to 5 and 2 to 3 year intervals. There's a lot of active research in endoscopic imaging and therapeutics as well. So we'll just move over to the next polling question. I might hand over to John.
Unless there are any final questions that are coming through.
The only real questions that came through was, what are the risks of doing the radiofrequency ablation?
Okay, so they're quite small. There have been perforations, but they're quite rare.
Mm-hmm.
The most common side effects or adverse events from the ablation are chest pain. That's not uncommon because you're actually heating the esophageal mucosa, and you often get chest pain, but this is relieved with high-dose PPI, and we often use Carafate, which is a mucosal adhesive, if you like, and it basically protects the mucosa. Post-ablation stricturing is another problem that certainly can occur, but that's fairly easily managed endoscopically. Often with Halo, I showed a very nice diagram that it all was completely disappeared, of course, but often it requires more than one go at completely eradicating it, and some people can have up to about 4 or 5 goes.
Can it worsen gall?
Not usually. We're very careful to not ablate the gastroesophageal junction too much, although you can, but it usually doesn't worsen reflux. Reflux is the functional part of reflux has nothing to do with the squamous mucosa. It's actually got more to do with the lower esophageal sphincter, and this basically doesn't affect that much.
Okay. There's a lot of questions coming in about PPI use and how long you can use PPIs for. I kind of feel like we need to do another session on PPI.
Yeah, look, I think John and I were speaking about this earlier, and I thought that might be the case. I mean, there's been a lot of bad press about PPIs over the last few years. And I would say you use it when you need it. You use it certainly for symptomatic patients. For people that have got gastroesophageal reflux disease, that's certainly erosive. And so me as an endoscopist, if I'm endoscoping someone and I actually see erosive esophagitis, I treat them with PPI at a reasonable dose, and that's 40 milligrams of, you select your best one, and 40 milligrams for about 1 to 2 months, and I tell them to have that daily and then stop it. And the recommendation is stop it and see what their sort of rates of symptoms come back. And then you basically evaluate the frequency of reflux that they get over the week. So if it's daily reflux, they're going to need regular PPI. If it's infrequent reflux, they might not need it and might have PRN type PPI.
Great. And one last one, H. pylori.
Can I hold on?
I thought you might talk about that later.
I will, but I will say one thing here, because people might read about the paradox of H. pylori and esophageal adenocarcinoma, because there has been this link, and on one of the risks of esophageal adenocarcinoma is actually eradication of Helicobacter pylori. And the reasoning behind that, or I should say past pylori infection. And the reason for that was H. pylori may cause atrophic gastritis, which causes hypochlorhydria, which is low acid output, rather than antral type gastritis, which causes hyperacidity and that might worsen your reflux. And if you eradicate the former, which is basically when you've got gastritis that causes atrophic change and low acid, then your acid comes back and your reflux can get worse.
Okay, thank you.
Okay, thanks, Alex. So we're going to move on now to issues of symptomatic diagnosis and start with the next polling question.
I'll let everyone read that because I don't have it up there at the moment. So have a read of this question, and I'll put the question up in a second.
All right. Okay.
There weren't enough characters available for me to put the full question in. So.
Oh, right. Sorry, too long a
okay.
question. I'm going to have the same problem with the next one too.
Everyone's got it.
They can all see the question. Okay. I can't quite see the numbers now. So this is about an even split of 5 and 15%, is that right?
Pretty much. There's a few
And
in
a
the
few
few
at
at
the
2
2
and a few at
33%.
33%. There's a pretty even split between 5 and 15.
Okay, I will come on to what the actual answer is as we go through this.
Showing everyone the results there.
So obviously when we think about trying to detect cancers in general earlier in primary care, we try and think about, well, what are the red flag symptoms? And in this particular case, what are the red flag symptoms of esophageal gastric cancer? The problem that we have in primary care is there's probably only one single red flag that is reasonably predictive of esophageal cancer, and that is dysphagia. But it's a difficult diagnosis to make, and they say this is based on data from a large survey of patients treated at the Victorian Comprehensive Cancer Centre, and one of the questions that was looked at in this survey was about the number of attendances to a GP before they were referred on for a suspected diagnosis. And this was done across multiple cancers. What we found was that esophageal gastric cancer was one of the cancers associated with a much higher frequency of multiple GP visits before referral, which we think is reflective of the challenges of recognizing this symptomatically early on, and relates to what we talk about as the symptom signature of cancers. Some cancers have much clearer, precise symptom signatures, like breast cancer and melanoma, but things like esophageal gastric cancer and pancreatic cancer as well have much weaker symptom signatures, and we think that's the explanation for why patients often have multiple visits to their GP before it becomes clearer that a GP should be considering this as a possible diagnosis. This, of course, is a challenge for many cancers in primary care because the symptoms of cancer, as they present in primary care, they're often very common symptoms in the community, and they often have much more common benign explanations. The chart I'm showing is really a reflection of that. These numbers are the positive predictive value of individual symptoms, or in some cases abnormal test results. And in this top line, this is thinking about single symptoms and the likelihood of somebody aged over 50 who presents in primary care with one of these symptoms of having OG cancer. And you'll see here, this is why I said dysphagia is the only true red flag with a probability of just under 5%. That still means 19 out of 20 people who present with dysphagia won't have esophageal cancer. But it is truly the only single red flag symptom in primary care. There are, of course, some other common symptoms that you need to think about, but nausea and vomiting, dyspepsia, epigastric pain, reflux, these are such common symptoms on their own in primary care that they're very weak predictors. So this is, and if you then start to look at the rest of the chart, this is how combinations of symptoms or abnormal test results can start to give you a bit more information. So for example, here we have if we look at the combination of nausea and vomiting and reflux, then that starts to increase your risk slightly, so to 2.3%. Weight loss in the context of nausea and vomiting, or dyspepsia, or epigastric pain, again, starts to raise your probability of an OG cancer, but again, not very high. As I said, only dysphagia is the really true one, and only in combinations do you really start to get even moderately high prediction of symptoms. This is why diagnosing OG cancer in primary care is challenging, even in a population, as I say, who are aged over 55, when their risk of OG cancer starts to rise. So in Victoria, Alex and I have both been involved in the development of these new guidelines that are aimed primarily for use in endoscopy units to support the triage of patients referred for an upper GI endoscopy. But they're very much based on this type of evidence from mainly primary care populations, where you start to think about how combinations of symptoms and age and abnormal test results can be applied to identify people who require more urgent gastroscopy, and those who might actually not require an endoscopy at all, and those who can afford, you can probably safely leave them on the waiting list because they're very unlikely to have an undiagnosed cancer there. They may still require an endoscopy to make a diagnosis and to inform treatment, but you're unlikely to be leaving them on a waiting list with an undiagnosed cancer. So I'm going to talk us through some of the particular symptoms and symptom combinations that are from this guideline. So if we think about urgent upper GI endoscopy, there are really only sort of two very strong predictors. One, as I said, is dysphagia, and dysphagia at any age in an adult is a significant enough symptom to warrant referral for a very prompt endoscopy. The other one that wasn't in that chart that I showed you, and mainly because this is usually an emergency presentation, is hematemesis and melena. But I'm sure there are many GPs on the line who have experienced patients who have come and seen them about 2 or 3 days later saying, oh, I vomited the other day and noticed some blood in my vomit. They still require an endoscopy. And of course, we're assuming in this context that there is this delayed presentation and that they're hemodynamically stable and not requiring immediate admission. But there will be patients in general practice who certainly present like this, and assuming that they don't require immediate admission, they still do require an urgent upper GI endoscopy.
John, can I just have so in terms of the dysphagia, I think one of the other clues that can be very helpful here that might discriminate, and it doesn't always work, but it's actually really worthwhile, is the term progressive dysphagia. And that's something we all got taught in med school, and it really reflects the change of dysphagia from liquids to solids. So basically, solids to liquids. So solids are the first things that get affected, and then eventually you can't have liquids. That progression is very, very suggestive of a mechanical obstruction and a growth. And that certainly I would almost put an extra red.
Yeah, double red. Yeah, thanks. So we have another polling question.
How quickly should you refer someone?
Yeah, so in the optimal care pathways, the recommendation is for these types of presentation, ideally they should be scoped within 2 weeks.
That's a real challenge.
It is.
In certainly the public system, that's a real challenge.
Yeah.
You know, you'd see the categorization guidelines say less than a month.
Yeah.
Because effectively, from a scheduling perspective, that's effectively probably the closest that you're going to get. Mainly because many public hospitals don't necessarily have open access, and so you may need to go through a clinic to actually get that. Now, some have hybrid models where you can actually have a slightly open access for some of the urgent ones, where you get an immediate triage by either a head of unit or an advanced trainee or someone like that that reads the referrals. And certainly if they read a referral from a general practitioner that says progressive dysphagia, I can tell you that that's going to be on the next list or very soon after.
If a patient just turns up and says, I have some trouble swallowing my food last night, or a food got stuck in my throat, that would warrant it?
Not always, I would say, but I mean, a lot of them actually, the food getting stuck, we see in emergency anyway. So often they will get one anyway.
Yeah.
If it's truly stuck and
If
they
it's
really,
truly stuck.
If it passes, they had trouble swallowing.
That's certainly what, you would flag.
Yep.
So we have our next polling question.
Should we read this out?
Do we need to read this out?
Maybe read it out.
Okay, so Mary, she's 57 and she's come to see you after being found to be anemic when she went to donate blood. She's asymptomatic. Her last period was 5 years ago. She's a non-smoker, drinks 10 units a week and is vegetarian. Her HB is 111 grams per litre and MCV 78. Her serum ferritin is low and her total iron binding capacity is increased. And I'm asking you, what will be your next step?
The poll is up. Jeez. That's about 70%. So about 60% of people say refer for colonoscopy or gastroscopy, and then 23% say order some tests.
Okay, and a few would prescribe iron supplements and repeat the iron studies, just a small number.
Small number.
Okay, so this is an algorithm that was actually originally published by the British Society of Gastroenterology a number of years ago. It's been adopted internationally and again is incorporated in Australian guidelines now as well, which is really a flow chart for anemia or particularly microcytic anemia and or iron deficiency. And interestingly, the first test that they recommend, rather than going straight into endoscopy, is actually checking for celiac serology. Because of course, malabsorption from celiac disease is an important potential cause, even in an older woman like this. And therefore, actually, if you had positive celiac serology, then you would be doing a slightly different form of endoscopic investigation. You would be able to rule out the need for colonoscopy as well. And so that's why this first suggestion is to do celiac serology. And if it's positive, then you would confirm celiac disease with an OGD and a small bowel biopsy. Now, you'll notice in the options I gave before, the suggestion that as well as doing this, that you might add in an immunochemical FOBT test. Because the usefulness of an IFOBT is it actually, if that were positive, it points to the source of blood loss as being colonic. And therefore, you could potentially rule out the need for an upper GI endoscopy at that point. So while this is not officially in the guidelines, I think there is growing recognition that FOBT tests have a role in the assessment of symptomatic patients as well, or anemia. Would you agree with that, Alex?
Yeah, look, I think that's not unreasonable here. I noticed that a lot of people wanted the gas colon. I think, you know, that is very reasonable to actually do it. I think the celiac serology can give you a fairly quick answer, and by the time you're waiting for those procedures, which you may need to do anyway. I must admit that if we have a referral as an endoscopist for iron deficiency anemia, we do both gastroscopy and colonoscopy at the same sitting. We always do small bowel biopsies, irrespective, because even if we don't have celiac serology at hand. but they're incredibly sensitive and very specific. So they're good tests to have. One of the other possibilities there, although it may not fit into this algorithm, and it's probably why it's not included, is HLA testing for DQ2 and DQ8, which can exclude people from a celiac diagnosis if they do not have DQ2 or DQ8, because it's very unlikely if they don't have the genetic susceptibility.
Right. Regardless of their celiac serology.
Yeah, so I mean, celiac serology could be completely negative because they might be, she's vegetarian, she might not be having, gluten in her diet. And so, the TTG might actually be low titer because it's like a well-controlled celiac, if you like. So at that particular time, it might be a negative, and it might be a false negative.
Sure. So we might just carry on while we talk through. So assuming that the celiac serology is negative, if it was a premenopausal woman, then you want to review their symptomatology. If they have upper GI symptoms and no family history of colorectal cancer, then the suggestion is that you would just go straight to an AGD to begin with. And only if that was normal, then you might consider going on to colonoscopy. If in postmenopausal women or all men, then the suggestion here is potentially doing an upper and a lower endoscopy, but you might, as I said, potentially think about the role of FOBT.
When you do an FOBT, is it always necessary to do 3 samples?
So interestingly, in the National Bowel Screening Programme, that's a 2-sample test, and that is sufficient.
Great.
Yeah. Obviously, the more samples you force people to have, the poorer compliance. Yeah. So that's iron deficiency anemia. We're going to talk now a bit more about reflux, and again, these comes from those Victorian guidelines where we're starting to think about combinations of symptoms, age, and test results to help define urgency for investigation. So these are the features where you want a more urgent endoscopy. So somebody with reflux who's aged over 55 with any additional symptom as listed below, so dyspepsia, upper abdominal pain, persistent nausea and vomiting, or weight loss. And again, if you think back to that symptom risk tool, that's where these combinations of symptoms, particularly in people over 55, where their risk of an undiagnosed AG cancer goes up. But also importantly, even if they only have a single symptom, this is where additional blood tests can be useful. It's unlikely that you'd be ordering imaging, but just occasionally there may have been imaging ordered as well, and if there's or abnormal imaging too, but you would be unlikely to see that. But we've talked about markers of anemia, but raised platelets are also increasingly being recognized as an additional useful piece of information to identify people at higher risk of cancer. This is a recent meta-analysis of studies that have looked at how useful a raised platelet count is ordered in general practice at predicting the risk of an undiagnosed cancer in primary care. And that you'll see actually, for all of these different cancers, you're at a high risk of an undiagnosed cancer with a raised platelet count. The risks are higher for certain cancers, although bearing in mind some of these confidence intervals are a bit wider. But the particularly important ones are lung, esophagogastric, and colorectal, possibly ovarian too. So it's just worth recognizing that a high platelet count is certainly worth repeating, because actually there are separate studies that are reported in here which show 2 raised platelet counts further adds to the predictiveness of an undiagnosed cancer. And it's certainly worth going back to take a good history to see if there are potentially important symptoms to make you think about investigation for a potential cancer. And that's why, going back to these guidelines, we've added in raised platelet count as an additional abnormal blood test to think about in the context of upper GI symptoms. Now we're moving on to dyspepsia. Again, these are three categories of urgency. The most urgent, again, are people with dyspepsia aged over 55 who have an additional symptom, or again, who have abnormal imaging or signs of either anemia or a raised platelet count. But if they just have dyspepsia, then this is where H. pylori treatment comes in, and we will come on to that in a moment. If they're aged over 55 and non-responsive to a PPI and or H. pylori therapy, or they're H. pylori negative, then they should be having a slightly less urgent endoscopy, usually within 60 days. Or again, if they're younger but have additional symptoms or additional abnormal blood tests, then that would bump them up to slightly more urgent. And only these group would be on a very long waiting list for endoscopy. Which moves us on to further discussion around H. pylori.
So I just have a few slides here on Helicobacter pylori, some of the conditions that have been published related to it. And of course, we would all recognize the Nobel Prize that was actually given to two Australians, Warren and Marshall, who actually made the association between peptic ulcer disease and H. pylori. Of course, gastric cancer has since been associated, and back in 1994 the WHO classed it as a class 1 carcinogen. It also is responsible for MALT lymphoma, which is mucosa associated lymphoid tissue lymphoma, which occurs in the stomach as well. There are, however, some extra gastric associations that people may have read about. One that's probably lesser appreciated is iron deficiency anemia. And the mechanism of that is actually because of that atrophic change that I said before. You get low acid, and you need acid to actually more efficiently absorb iron in your diet. And so it does interfere with iron absorption. But also ITP, and I've got numerous referrals from hematologists that have thrombocytopenia and want these patients' Helicobacter eradicated. And in fact, we've had some successes that I certainly share, and there's good evidence for this as well across the literature. So who do you eradicate with Helicobacter? So certainly peptic ulcer disease, I think we've got it. Early gastric cancer, and these are uncommon in our community, as our prognosis actually shows, but we still do get it. And I must admit the Japanese do this extremely well, where they can actually treat gastric cancer just endoscopically without any sort of adjuvant chemotherapy, no radiation. They actually just endoscopically remove these, and obviously will have high rates of Helicobacter, and they get certainly eradicated from their H. pylori. There's a condition that is called gastric intestinal metaplasia. This is kind of a pet hobby of mine, and I'm not going to bore you guys with it, but in effect, this is the Barrett's of the stomach. And in fact, the risk profile of progression to gastric cancer is almost identical to what I showed before with Barrett's esophagus progressing to esophageal adenocarcinoma. The problem, once you have this type of intestinal metaplasia, is often it's related to Helicobacter pylori that might have been there many, many years ago, but only a small proportion, or about half or less than half, actually regress once you get intestinal metaplasia. So some of them still actually progress irrespective of getting rid of their Helicobacter pylori. And this is thought to be the point of no return. Exactly when that occurs, I'm still trying to find out with research at the moment. So I'll let you know in maybe 10 years. But probably more importantly is this pre-malignant stage called atrophic gastritis, which is basically the precursor to intestinal metaplasia. And the evidence is that if you can treat the Helicobacter pylori at this stage, you get much better regression or less progression rate to gastric carcinoma. Unexplained iron deficiency anemia. Now I put the qualifier of unexplained. If you obviously have a good reason for iron deficiency anemia, it's probably not Helicobacter pylori, but if it's unexplained in any other way, then eradicating H. pylori may actually help. ITP, as I mentioned, vitamin B12 deficiency from usually an autoimmune gastritis that sometimes occurs with chronic Helicobacter infection can sometimes improve. MALT, and in fact, some of the early MALT lymphomas can actually be effectively treated just with Helicobacter pylori eradication. There is also this dyspepsia with no alarm symptoms. I think this is really important. This is what John was referring to with those other abnormal symptoms. Alarm symptoms classically are weight loss, bleeding, so hematemesis and melena, dysphagia, obviously, as shown in previous diagrams. And there is this strategy that John might allude to in a few minutes called test and treat. So basically, rather than endoscoping these people, you test them with a non-invasive strategy and then treat them on spec. And I'll talk about some of the strategies in a sec. Also, those patients that actually are going to have chronic non-steroidal use, and they're the osteoarthritis, rheumatoid arthritis, or other conditions that might need aspirin or non-steroidals, where they're susceptible to getting peptic ulceration. For prophylaxis, having Helicobacter as a cofactor will increase their chance of actually getting peptic ulcers. So getting rid of the Helicobacter makes sense. And this certainly comes from recommendations globally. So how do you test it? What tests do you use? In terms of non-invasive testing, I think one of the best is urea breath tests, and I think the simplest one is the carbon-13. Sensitivity and specificity is slightly different depending on which test kit you've actually got, but it's actually generally pretty high. And basically the methodology is this: the bug has got urease. You actually swallow something containing urea. The urea is broken down by the urease to release carbon dioxide, which is basically labeled with your marker of C13, and ammonia. That gets, carbon dioxide is very quickly absorbed in the bloodstream, gets to the lungs, you breathe it out, and you can actually detect it on a mass spec. Stool antigen tests are getting better and better. That's quite a sensitive and specific test at the moment. There's been quite a lot of studies of this over the last few years. Serology is good, but don't forget it's an IgG test, so it actually will be positive for past infection. It doesn't tell you anything about current infection. So specificity and sensitivity are reasonable, but don't use this to actually test for eradication. In terms of invasive testing, what I mean is someone having an endoscopy, what do you do? There's really two types of tests to actually detect whether it's present. This uses that urease type test. This is only one of multiple rapid urease tests. And you see basically a pH change over here from and this is actually the ammonia component rather than the CO2 component that's actually doing it. So it normally starts as yellow, turns to pink, and that's positive for Helicobacter, or positive for urease, which means effectively Helicobacter. You can take biopsies for histology, and you can actually stain up. There's now some very nice stains for Helicobacter pylori. The sensitivity and specificity, the specificity is excellent for this. Sensitivity is a little bit lower. And what I'm using, and I'll explain why in a couple of slides' time, more and more these days, is culturing of Helicobacter to look for sensitivity. And this is sort of a culture. Usually it's horse blood agar that we actually use. It's sometimes difficult to actually grow, but when you can, it gives you useful information about what it's sensitive to and what it's specific to.
Just 3 quick questions.
Yes.
If a family member has H. pylori, do you test the other family members?
That's a good point. And generally there is familial association of Helicobacter, and that's because of this oral spread. Yes is the short answer to that. I think it's not unreasonable.
Which of those tests are covered by Medicare for GPs?
I think the urea breath test is certainly covered.
Yep. And how long do you have to stop PPIs before you can do that test?
At least 2 to 4 weeks. I'd be safe and do it 4. It should be okay with 2, but you often do get false negatives and false positives. So the next thing I just wanted to talk about was therapy for Helicobacter pylori. There's a couple of these are actually pulls from Up to Date, which some people might use, and basically goes through what you would use for Helicobacter pylori eradication therapy as first-line therapy, and then what you might use as second-line therapy. And I'll go through the summary. So the reason for why there's complex matrices and why you just don't use Nexium HP7 or some PPI with clarithromycin and amoxicillin is because of this previous exposure to macrolide antibiotics, which may influence the sensitivity, and as well as this issue, which is clarithromycin resistance rates, which were previously very low, and I'll show you some fairly worrying data globally that have been published just this year. But generally, if you don't have any problems with clarithromycin resistance, you think that you're in a population that doesn't have it, you don't have a penicillin allergy, you use the classic clarithromycin-based triple therapy with amoxicillin. If you've got a penicillin allergy, you use metronidazole instead of the amoxicillin. And then if you've had metronidazole use, you go to bismuth quadruple therapy, and I'll talk about what that is in a bit later. So in terms of second-line therapy, and increasingly it'll be interesting to see what you folks are finding in terms of the real-world practice, what you're finding in terms of second-line therapy, well, the requirement for second-line therapy. Certainly in my practice, this is happening more and more, but I guess it's a very skewed population that I'm seeing. But basically, if you've used clarithromycin-based triple therapy as initial, and you have a penicillin allergy, go to the bismuth. If you don't have a penicillin allergy, you can go to levofloxacin triple therapy or bismuth, or a high-dose dual therapy of these. And you can use various combinations of these if you like. I won't belabor the point. This is a study that came out of the US earlier this year, and it basically shows, and I'm sorry, but they're small figures, but basically this shows the resistance of clarithromycin in A, metronidazole in B, and levofloxacin in C. And the color code is less than, I think it's 10% in yellow. The next one up is 10 to 25%, then 25 to 30%, 35% to 50%, and then above 50%. And you will see Australia, both in clarithromycin and metronidazole, rather worryingly. I knew about this with metronidazole, that greater than 50% of our population are probably resistant, but this is a concern. So more than 50%, at least in this study, and this is only one study, but probably needs further confirmation, have got primary clarithromycin resistance already in our community. Thankfully, levofloxacin is rather low, and so this is probably a reasonable second-line agent still, but we've got a question about whether we can use clarithromycin as first line. And in fact, anecdotally, in my practice, the problem patients that I've seen that haven't eradicated with first-line therapy have all been clarithromycin resistant. So in terms of how to eradicate, you certainly can still use these PPI Moxil clarithromycin for 7 days for those people that have not got prior metronidazole use or clarithromycin use in the past. One of the questions I wonder whether we're going to have to address is the 7-day period here. And I think increasingly the data is showing that we're probably having to go back to the good old days of H2 receptor antagonists when we used to use it in triple and quadruple therapy, where we used it for 14 days. And you'll see that the second line therapy are actually for prolonged periods, and you could either use the bismuth containing quadruple therapy. You can get bismuth in Australia. It is more difficult to get, but it is available. But certainly this is a much more amenable treatment using levofloxacin, a PPI and amoxicillin for those that are not allergic to penicillins. Now, third line therapy, you'll read different things. Some people actually say, okay, if you've used one of these second lines, then go over to the next one, the alternate ones as third line. My practice, and again, this is because I do endoscopy, is to actually endoscope these people, culture them, and actually be a bit more informed using evidence to which one you can safely use or not. Thank you.
So I might just briefly, just to highlight, part of the reason for flagging the H. pylori stuff is also in the context, as you say, around test and treat.
Yeah, right, sure.
And the potential, particularly in younger people, so under 55, who just have dyspepsia, if you can use a test and treat strategy to safely avoid them requiring a gastroscopy.
And I think that's the case, John. That's certainly in eradication guidelines that we've suggested. That's certainly been put out there. Dyspepsia is difficult because it sometimes has had difficult meaning, but also on its own, it's very difficult to know whether it's part of an irritable bowel spectrum or truly part of the process that Helicobacter pylori might be playing a role in. The data suggests that up to 50% might respond, but that's as good as you're going to get. So basically up to 50% of the dyspeptic patients might get a response to Helicobacter pylori, and therefore it's actually advocated as you suggest. So with just dyspeptic, no alarm symptoms, certainly you can do the test and treat, where you would test with one of the sensitive measures that have been outlined before. The simple one would be urease breath testing, and then treat. And then, of course, not to forget to check eradication. And that's one thing that people do forget to do, and they sort of treat them and then assume they're better, or if they do get better, and then not check 4 weeks later or beyond, off PPI and all the rest of it, off other antibiotics. You need to be off antibiotics for 4 weeks before you actually do these tests. And I would be recommending doing a urease breath test as a check for eradication.
Great.
Thank you. I think you just answered all of the questions that just came through. Can GPs prescribe levofloxacin?
I don't know.
I'm not sure if it's an authority script only. I'm not. Yeah.
That's the only one that you'll have to check. Those
We will double check that around whether it's an
authority
authority script or not.
Yeah, not sure
I'm
about
not
that
sure
one.
whether it's specialist only.
And do you keep patients on PPIs after you treat them, or you stop them, wait 4 weeks, retest?
Yeah, I would stop them. So if you're just treating to eradicate,
yep,
you just stop it. So it's basically treated for the duration, you stop it afterwards. The time that I would be continuing PPI therapy is if there was a peptic ulcer that you had to heal, you had to cure and heal up. That takes about 4 weeks at least of PPI therapy.
Okay. We've had some advice come through that they don't think it is PVS listed.
Yeah.
Right.
I
think you're right. I think it is a private script.
Yeah. So yeah, that's sort of come through there. That's it. I think we've come to the end. So thanks very much. There are a couple of resources through the Cancer Council website. Anyone who hasn't seen so far, there's 2 handouts that are available for download for you now in your sidebar of the webinar. So grab those now. I will be putting those up on the RACGP National Webinar Series website in the next couple of days. The recording will also be available in the next couple of days. But apart from that, the survey will come up as soon as the webinar finishes. So from the RACGP, thanks very much for coming along today, John and Alex. Thanks to Cancer Victoria, Melbourne University, and the Victorian Government as well.
Thank you very much.